Alrighty, we got chapter 6 here, documentation. Let's get started with the good stuff. Documentation is super important, very, very important. Get you fired in a heartbeat. Hopefully not, but it can. It does become part of the patient's medical record, of course, part of their emergency department chart, and kind of their permanent records, if you will. So it's a legal document. Keep all that in mind. EMS professionals need to know what constitutes a report, what must be included, who might read the report, when it must be completed, and what terminology may be used. And a lot of that is determined on a state level of what you have to include with all that. For every call, PCR should include objective information, subjective information, and then details of the patient care. Of course, PCRs, patient care reports, must be complete, accurate, and legible. There on the kind of the right-hand side of the picture, the guy is using a tablet to do his, or a laptop to do his ePCR. Legal implications of a PCR. Reports may include subjective statements from the patient, and they should not include bias or personal opinions from us. Omissions and error can result in errors in care, litigation, job loss, and a poor reputation is going to be a big one that you'll carry through EMS. If you write junky reports, then that's not going to be a good thing. Use a lot of redneck jargon that is not professional and looks badly on you and gives you a poor reputation as an EMS provider. And it looks bad on the industry as well. So, reports should be complete, well-written, legible, and professional, or professional, either one. Sloppy documentation implies sloppy care, and HIPAA has ramifications for patient care reporting, of course. HIPAA has everything to do with everything. They get into everything. Good old HIPAA. So the purposes of documentation, PCR's record of the patient's condition upon arrival, the care that's provided to them, changes in the patient's condition, and then the condition on arrival at the hospital. All that stuff needs to be included. You need to be able to paint a picture of the scene and the mechanism of injury or nature of the illness. To ensure timely billing, and this is what a lot of it comes down to, is our documentation that gets us paid and keeps ambulances on the road. You need to document your procedures that you performed, obtain insurance codes if necessary, depends on your system. Get your signatures that you're supposed to, and then a big part of it is document the reason for ambulance transport. And that table on the right-hand side kind of shows you some guidelines of why someone might qualify for ambulance transport. Many states now require EMS agencies to submit data to their state EMS office. State of Oklahoma does. Certain things that they pull from all of our PCRs that they keep track of and collect all that wonderful data. And then NEMSIS is a national level, let's see what it stands for, National Emergency Medical Services Information System, NEMSIS. And that pulls it on it from all the states. It pulls and creates its own database of EMS data that they can then look at, and they do a lot of studies, like retroactive studies, patient outcomes, stuff like that. And kind of helps us grow as an industry, define what we're doing good, what we need to work on better, stuff like that. EMS reports may be requested for medical audits and other educational activities, run reviews, QA, QI, all that good stuff, help us to be better. They may be used to calculate the number of times you performed specific skill. A lot of that stuff can come up later on when you're applying for promotions. They can pull, some objective data from all the candidates and say, all right, well, this guy can't even start an IV without taking 4 attempts. Then who says he needs to be a training person if he can't even start his own IVs? Or whatever it might be. But they can pull all that data later, especially if it's all computer-based. Always accurately document skills and attempted and performed with patient care. Don't falsify any of those documents. Don't check that it only took you 1 attempt to start an IV when it actually took you 3. If it took you 3, mark 3. You'll get it on the next one. Give you something to work towards. Most EMS reports are electronic nowadays, thankfully. Some of them are check boxes, drop-down menus. I mean, there's all sorts of different ones, and they all include some sort of narrative section that you can write in your own words. These are just some examples of different types of PCRs that are out there. There's probably a million of them. I don't know. Most agencies are shifting away from paper PCRs and using laptops and iPads and whatnot to do all the ePCRs now. And of course, computer-based PCRs should be NMSIS compliant. Any of these companies that are making these ePCR programs, they're NMSIS compliant. Every call requires documentation, even if it is a canceled call. It might be a very quick documentation, but it should still have some sort of documentation. Standard items documented on every call. Run data, patient data. Run data might include your incident times, location, responding units, crew members. That's kind of the very minimum. And then if you actually do encounter a patient, chief complaint, level of consciousness or mental status, vital signs, demographics, all that good stuff. Should have objective observations of scene. You know, if you've got a patient laying in the front yard, supine, that would be an objective observation of the scene. Treatments, the effects of the treatment. If you gave somebody a anti-nausea medication and they said they felt better, well, that's the effect of treatment, and they, weren't throwing up, then it's something you need to document. Changes in patient condition, if they deteriorate or improve. Strokes is a big thing. If someone's stroke symptoms resolve or worsen. Service treatments may be scheduled or unexpected. So there's that. Oh, it's just something you have to document, whether it was like a 911 call versus a scheduled transport to a doctor's office or something like that. All that stuff has to be documented. Document whose care you left the patient. That avoids abandonment charges or allegations of abandonment. Make sure you're putting in there what facility, the nurse's name, all that good stuff, or family members, all that. Make sure you're getting your signatures that you need whenever you get those, and it is pretty much required. Care prior to arrival. Dispatch may direct caller to provide care prior to arrival. A lot of times, and at least in our system, if patient is complaining of chest pain, the dispatch may direct them to go ahead and take aspirin. So we need to make sure we're putting that in our information that the patient took, 324 milligrams of aspirin prior to our arrival, or anything that, they might have received that might pertain to our treatment. Also on that, if first responders get there and start treating the patient, then you need to make sure you're putting what they did prior to your arrival, put all that in there. And you'll get familiar with what your system requires. Competent adults have the right to refuse care. Keep that in mind. You can't kidnap anybody. We're not in the business of kidnapping. I don't know how many times I've had to tell people that. Son or daughter insists that the mom or dad has to go. The mom or dad says, nope, I'm not going, and they're able to answer all your questions appropriately. Well, we can't kidnap you. So sign here, press hard. We'll see you later. Call us if you change your mind. The patient should know his or her current situation, the right to receive and refuse care, and the consequences of refusal of care. And so that kind of goes into the next step of this. If you go into a house and, patient's, family member called for chest pain, then you go in there and you pop a 12 lead, and the patient's having an active STEMI and having a big old heart attack, but they're refusing transport. Well, then you need to make sure that you're talking to that patient, informing them of what's going on. Get online med control if you have to, call the doctor, have them talk to the patient, use all that stuff to make sure that the patient understands the consequences of not being transported. Fully informed refusing. They must understand it. Information must be given in a language that the patient understands, not tons of medical jargon. If I walk into someone's house and say that they're having a STEMI, nobody's going to know what that means. But then if I walk into that same person's house and say, hey, you're having a heart attack, everybody knows what that means. And so make sure you're giving it in a language that anybody can understand. Of course, document it, write it all down. Have the patient write out in their own words why they don't want to go. Get them to sign it. Get it witnessed by an observer, family member, something like that, PD, whoever's there. Just make sure they're very well informed. Unresponsive patients may be treated under implied consent. You can treat them unless you have, if they've got a DNR strapped to their chest and they're in cardiac arrest, then that's one thing. But for 99.9% of patients, if they're unresponsive, treat them. Be familiar with individual state laws related to consent and confirm every effort is made to ensure patient's best interest. Know what's the law for like medical power of attorneys, emancipated minors, stuff like that. Know what's pertinent in your area. If you disagree with the refusal, know the next steps like we kind of talked about. If you have to get online med control, every EMS agency should have that kind of defined. If you pop 12 and see that STEMI, then okay, here's the next step that I've got to make. The patient has to speak with a physician and just know what you need to do. If you need to have a witness for that, it's always a good idea if you can have a witness, family member witness, 2 or 3 witnesses, and they can write down in their own words as well what we all tried, but the person just did not want to go. Evaluate the patient's mental status. Make sure they are of sound mind. That can be a big thing. If someone is, A&O times 2, then can you go on implied consent, or is that going to be actual adequate for determining the patient is competent? Lots of gray areas, but for the most part, if you walk in there, at some point somebody called 911 and somebody wanted help. So if you walk in there, do a full assessment, say, hey, this is what's happening. This is why you need to go to the hospital. I know you don't want to, but this is what I would recommend. And the way I do it personally is I say, if you were my mother or father, if you were my mom, this is what we would do. And when you put it in those terms of this is what I would do for my family, it really conveys a strong message to them that, oh, okay, well maybe I need to do that. If you walk in there, it's like, I don't care. If you want to go to the hospital with us, hop up here, let's go. Well then, of course, they're going to be more likely to refuse. But if you can really get on their level and connect with that patient, then they'll usually do what you need to do and allow transport. And of course, make sure they are familiar and they know that they can call EMS later if they decide to ever change anything. Document everything. Document. Propose alternate methods of care, alternate methods of transport, calling in home health, all that different stuff. This table here is a good table to look at and are different components for a thorough patient refusal. Make sure you're hitting all those different points there. OSHA guidelines require workplace injuries to be logged. There's probably a specific spot on your EPCR that you fill out that designates whether it is a workplace illness or injury. And then they may require additional documentation. A lot of times they'll get that after the call's over with. They'll want a copy of your PCR and they can get with your director or whoever's in charge of disseminating all that information. Document precautions taken and protective gear worn by the patient. Be familiar with state requirements for all that good stuff. Mass casualty incidents, all these are special circumstances. Occupational exposures, abuse and neglect cases, physician's arrival, mutual aid services, unusual occurrences, controlled substances, and of course follow the processes of your medical director. Any of these things could really be gray areas for EMS, unfortunately. And so know what your agency requires for, like, in the state of Oklahoma, we have to report abuse and neglect, and passing that information off to DHS or the nursing staff. Know what is required of you, or what you're going to do if a random doctor shows up on scene of a car wreck and starts barking orders. Well, okay, is that legal? Can you do that? Know what you need to do. The good old narrative of your PCR. Narrative should be detailed, accurate, and complete, and very specific. It is you painting a picture of the scene and what you did for the patient. Narrative section should document consultations, orders from medical control, and refusal situations, of course, if any of that does apply. Many methods for narrative documentation do exist. Know your agency's preferred method. I will say most widely accepted is either going to be the chart or the SOAP format. Chronological order, I know around here it's not accepted, but it is listed here, so sure, you can use it. It's just a story format from Dispatch of that's kind of what I used when I first started, and then I was forced to change to chart. But just chronologically, I was dispatched to this, we pulled up on scene, I saw this, and it goes through it that way. But chart and SOAP are a little different. So you got SOAP, which has subjective information, objective information, your assessment, and then your plan for treatment and transport. It's similar to chart. Chart just breaks it down with a couple extra letters. Chart, you get C is your chief complaint, then you have your history, assessment, treatment, transport, and exceptions. I will say, going through paramedic school, now is your time to experiment with the different PCR narratives. If you have an employer that maybe accepts 2 or 3 different styles, find out what they accept and then start experimenting with what the different ones, and find whichever one you like best. That's what it really all comes down to, is what it might be what you're forced to use, or it might be what you prefer, personal preference. And then this is you're going to be doing a lot of patient documentation through paramedic school, so it's a good time to practice these different narrative styles and choosing one and getting good at a certain style. There's lots of resources out there to give you some boosts and stuff to look for on your different narratives. Google it. That's all I got to say. Google a good chart format, and it'll give you lots of tips. There's also body systems approach, which is a head-to-toe approach, and whatever it comes down to, use one reporting method consistently. Get your grammar and spelling. They're essential. You can always, all have smartphones now. Google whatever word you're not sure of spelling. If you say the word, a lot of times they'll come up with a correct spelling on your phone there. Include pertinent negatives and spoken accounts. Pertinent negatives are patient denies chest pain, patient denies neck or back pain, patient denies shortness of breath, patient denies recent illnesses, patient denies taking his medicines in the past 3 days. All of those are pertinent negatives. Make sure you are including those if need be. I include it on every call I run. Patient denies chest pain and shortness of breath. Patient denies recent illness of fever, nausea, vomiting, chills, diarrhea, cough. Patient denies neck or back pain. Also, patient denies neck or back pain upon palpation. Once you feel them, that can be for your trauma. All those are pertinent negatives. You need to make sure you're putting those in there. Don't just leave them out of your narratives. All this goes back to having a nice, clear, concise PCR and ePCR. Shows that you care and implies that you're doing a better job of taking care of your patients. Also include spoken accounts. Family member states such and such. Put that in quotations. Put the family member's name. All that good stuff. Information should be comprehensive and concise. Complete all sections, even if not applicable to the call. It depends on what you're using. I know a lot of most modern ePCRs won't let you finish a report unless you have all the red X's taken care of. Handwritten reports should be legible, written in ink, neat and easy to read. If you do have to make a I think it talks about it in a minute, actually. Place reports in a secure location, of course. Complete them in a timely manner. Don't wait days or weeks to complete those forms. That's a big thing, especially with cardiac arrest and stuff. If a patient is an organ donor, they need that PCR as quickly as possible. That way they know what medicines were given, all that good stuff, and that way they can find out for organ donation reasons. Written record should be left with the patient. Drop report or transfer reports may be used. All of ours now, for my system, is electronic, of course, so it's all taken care of. We don't actually leave anything physically in paper with the patient. It's all electronic. PCR should not contain jargon, slang, or personal opinions. Someone does not have a pot knot on their head. They may have a hematoma, but don't use a bunch of jargon or slang. Personal opinions. Patient appears drunk and disorderly. Try to leave that out. Patient has altered mental status and is hostile. That's very subjective finding, or that's a very professional way of putting it, and is good for documentation. Be sure your documentation is not libelous and only true and accurate statements. Because this is a legal document, you don't, in theory, you could ruin a person's reputation based on your documentation. So that's why it is very important to be accurate, be true. I'm not saying omit anything, but don't smear somebody just because, if that makes sense. Review your report before submitting it, of course. Proofread it all. Make sure you got your periods where you need them, capital letters, all the good stuff. Written reports do reflect on the paramedic, kind of like we talked about. Sloppy PCRs reflect poorly on us. Inappropriate, inaccurate, and poor documentation can adversely affect patient care. And, that can go for a lot of things. If you pass off patient care and you give your PCR over to them, but it never said that you gave, 200 micrograms of fentanyl, then it could result in overdose if they go ahead and give another 200 micrograms of fentanyl or whatever it might be. It can have some adverse effects on the patient. Legal implications, of course. They can come after you for that. Affect the patient's paramedic's reputation. Man, they just keep talking, kind of harping on that. And part of being a good paramedic is completing paperwork and reports and doing that in a timely manner. Seek help if needed, especially as you guys are going through school, as you go through orientations, internships, all that good stuff. Seek help. Get some of those more experienced guys to come in and help you, especially if you're having trouble with your reports or what your agency that you work for is requiring. Make sure you're getting that help, and so that you can do good quality reports. You'll get plenty of practice, trust me. If a revision must be made, I knew we'd get to this. Note the date and time of the revision, include purpose for the correction, and never discard the original. And then also only the person who wrote the report can revise it. If you need to change something, if you're using like a paper report, then you just simply cross out. Actually, I don't think. No, it doesn't. Okay. If you're using a paper report, put a single line through the statement you're deleting and then initial it and date it. And then write out the new statement. Don't try to scribble it all out or use white out or anything like that. Just put a single line through whatever statement you are correcting. A lot of times on your ePCRs, there's a way to add an addendum, and just be familiar with whatever you got. Follow your protocols. There you go. Most electronic systems allow for amendments or addendums, and billing information may be needed, of course. Always be honest and thorough in your documentation. Loss reports have huge legal implications. Ensure reports are complete and turned in on time. Do not keep copies of your reports. Boy, that'd be a big stack after you've been doing it a little while. Don't keep copies of all that stuff. Accurate timekeeping is essential, and that's where it kind of falls on you and dispatch to keep track of all that good stuff. Keeping track of when the call was received, dispatch time, en route times, arrival at scene time you got, at patient contact time, when you administered certain medications or did certain procedures, when you went to the hospital, got to the hospital, transferred care, and then you're back in service. All that good stuff can be tracked. Use military time, of course, 0 to 2400 or 2359, I guess. We'll use that for everything. Makes everything a little bit more simple. Takes a little getting used to if you're not familiar with military time, but it's not too bad. Oops. Oh, look at that. We are done with this chapter. So, documentation, very, very important. Practice, practice, practice. Use this time in paramedic school to get familiar with what format you want to use. Try them all out. If you work for an agency, figure out what they prefer and get after it. That's all I got to say. Thank you.